A single 81 milligram baby aspirin. I mean, it's a pill smaller than a Tic Tac.
Yeah, barely even notice you're taking it.
Right. But it has the power to just completely neutralize a $1,000 regenerative medical procedure.
It really does. It's kind of wild.
And if you attempt to solve that problem by, simply stopping the pill to make the procedure work, well, you could trigger a catastrophic, life-threatening stroke.
Which is obviously the worst case scenario.
Exactly. So welcome to the deep dive. Today, we are looking at this really fascinating collision between cutting-edge wellness and, well, everyday cardiovascular medicine.
And it is such a common collision, too.
It is. We have a pretty robust stack of sources in front of us today for you. We've got clinical trials from the Baylor College of Medicine, some urology clinic guidelines, and these incredibly specific protocols from pain physicians and cardiologists.
Yeah, it's a great mix of data.
And we are zeroing in on one highly specific, vital question today. Can the O shot, which is a very popular regenerative therapy for women's sexual health, can it be performed safely and effectively in patients who are taking a daily low-dose aspirin or other anti-platelet therapies?
It is a phenomenal question.
Yeah.
Because, it sits right at this intersection of aesthetic wellness and critical cardiovascular health.
Right.
We often tend to sort of compartmentalize our health. We view the daily pill organizer as mundane background noise, you know? And the elective wellness treatment is seen as this isolated, miraculous event.
Like they exist in two totally different universes.
Exactly.
Yeah.
But the human body does not compartmentalize. The biology is totally systemic.
Okay, let's unpack this, because to understand the conflict here, we first really need to understand the therapy itself.
Definitely.
For anyone who hasn't encountered the literature on this, the O shot or orgasm shot is this non-surgical procedure designed to improve female sexual health.
Using regenerative medicine specifically.
Right. It uses regenerative medicine to enhance sexual pleasure, increase arousal, and it can significantly reduce symptoms of urinary incontinence and vaginal dryness.
And it's important to note, it does this without synthetic chemicals.
Exactly. It utilizes PRP, which stands for platelet-rich plasma, and that is derived directly from your own blood, from the patient's own blood.
Yeah, the key term to focus on there is autologous.
Autologous, right.
Meaning it originates from you. The actual clinical process is pretty straightforward, but the biological mechanism behind it is just incredibly sophisticated.
So walk us through that. How does it actually work in the room?
So a small volume of blood is drawn from the patient's arm, and it's placed into a centrifuge.
Basically a high-speed spinner.
Right. The centrifuge spins the blood at a very calculated velocity to separate its components by specific gravity.
It pushes all those heavier red blood cells down to the bottom, right?
Yeah.
And it leaves the plasma, which is basically the liquid gold, sitting right at the top.
That's a good way to describe it.
And sitting right in that plasma is this massively concentrated volume of platelets.
Yep, completely packed with them.
Those concentrated platelets are then extracted and injected into the highly vascular tissue of the clitoris and the anterior vaginal wall.
Which is where the magic happens, so to speak.
Yeah, I always like to think of platelets as the body's elite first responders. I mean, we generally know them for their ability to form physical clots when we get a cut.
Sure, like biological spackle.
Exactly. But they are so much more than that. They carry this massive payload of signaling molecules.
What's really fascinating here is the sheer density of active biomolecules inside just a single platelet.
It's like a tiny pharmacy.
It really is. Within the alpha granules of these platelets, there is this abundant source of growth factors.
Right.
And when these platelets are injected and then activated in the tissue, they undergo something called degranulation.
Degranulation. Okay, so they sort of pop open.
Pretty much. They release these growth factors, which basically act as a biological command signal to all the surrounding tissue.
Telling it to wake up and get to work.
Right. They stimulate local stem cells, they enhance collagen synthesis, and they promote angiogenesis.
Angiogenesis, which is the formation of entirely new blood vessels.
Exactly. They even stimulate the growth of new nerve endings.
So if we think about this practically, doing a PRP treatment is essentially like hiring a highly specialized premium construction crew to rebuild and revitalize a neighborhood.
I love that analogy.
The platelets themselves, they are the construction crew. And those growth factors, the VEGF, the PDGF, those are their tools.
Right, the hammers and nails.
Yeah. So they arrive at the injection site, unpack their tools, and start laying down new vascular plumbing, which, helps resolve the urinary incontinence.
Right.
And they rewire the electrical system, which improves nerve sensitivity. And because it's your own blood, the risk of an allergic reaction or rejection is practically zero.
Yeah, the baseline safety profile of an autologous treatment like this is excellent, assuming a healthy baseline for the patient, of course.
Right.
However, and this is the big catch, this is a procedure that fundamentally relies on two specific mechanisms to work.
Okay, what are they?
First is platelet aggregation, which is the platelets physically clumping together to form a matrix. And second is a localized, acute inflammatory response.
Oh, wow. Okay, which introduces a really interesting paradox for you listening.
hmm
Because, I mean, we spend billions of dollars in the wellness industry trying to fight inflammation.
Oh, absolutely. It's the enemy.
We take supplements, we sit in ice baths, we do red light therapy, all to lower systemic inflammation.
Right.
But in the context of PRP, acute localized inflammation is the absolute prerequisite for tissue healing. Like,
Oh.
if you don't have that initial inflammatory response, calling the construction crew to the site, nothing gets built.
That is a vital distinction to make because chronic systemic inflammation, that is destructive.
Right.
But acute localized inflammation, that is constructive. PRP is designed to artificially trigger that necessary constructive inflammation.
Yeah, it jumpstarts the whole process.
Exactly. The platelets must clump together, and the localized area has to inflame to signal the release of those growth factors we talked about.
Okay.
But if a patient is taking a non-steroidal anti-inflammatory drug, an NSAID, they are introducing a chemical whose primary job is to suppress that exact biological pathway.
And this brings us directly to the Baylor College of Medicine study that was published in the American Journal of Sports Medicine.
Such an important study.
Because if you're listening to this thinking, well, I only take a tiny 81 milligram baby aspirin, surely a dose that small isn't enough to ruin a $1,000 medical procedure.
Yeah, people think it's too small to matter.
Right. But this study proves exactly the opposite. Now, just for clarity, the study looked at normal PRP in healthy men, not women receiving the O shot. But the cellular mechanics of blood plasma and aspirin, they are universally identical across human biology.
Oh, totally. The underlying physiology doesn't change based on the specific application or injection site.
Right. So what did the researchers actually do?
Well, the Baylor researchers took 12 healthy participants, and they meticulously measured the baseline growth factor levels in their normal, untreated PRP.
So they got a baseline of their natural tools.
Right. Then they put this group on that standard 81 milligram daily dose of aspirin for 2 weeks.
Just a standard baby aspirin?
Just a baby aspirin. On day 14, they drew their blood again, created a brand new batch of PRP, and remeasured the chemical payload.
And the data was just stark. I mean, they documented a robust, severe decline in the most crucial regenerative tools.
The drop was really significant.
We're talking about massive drops in VEGF, which is the specific growth factor responsible for building those new blood vessels we mentioned, and TGF-beta, which commands the tissue repair.
Right. And to understand the mechanism behind that decline, why it happens, we have to look at something called the cyclooxygenase enzyme, or ECOX.
Okay, getting into the biochemistry.
Just a little bit. So aspirin works by inhibiting the COX-1 enzyme inside the platelet. When you block COX-1, you prevent the synthesis of a lipid called thromboxane A2. And that is the exact chemical the platelet needs to aggregate and degranulate.
Okay, here's where it gets really interesting. Aspirin doesn't just block the enzyme temporarily, does it? It destroys it.
Yes.
The Baylor study highlights that, unlike ibuprofen, which reversibly inhibits the enzyme, aspirin causes irreversible inhibition.
Irreversible. That is the key word.
It permanently breaks the mechanism inside that specific platelet.
And that irreversibility is really the crux of the whole issue. The cellular biology of a platelet explains why.
How so?
Well, most cells in the human body possess a nucleus, right? Which holds DNA.
The instruction manual.
Exactly. The manual required to manufacture new proteins and enzymes. But platelets do not have a nucleus.
Wait, really? No DNA at all?
None. They are essentially just fragments of much larger cells called megakaryocytes, which reside down in your bone marrow.
Okay.
Because circulating platelets lack DNA, they have absolutely no way to manufacture new COX-1 enzymes once the aspirin destroys their existing supply.
Wow, so the platelet is just permanently disabled for the rest of its natural life.
It's completely neutered.
It's circulating in your blood, but it's completely useless for regeneration.
Yep.
Going back to our analogy, you go through all the trouble of paying for this premium construction crew. You draw the blood, you spin it down. But because of that tiny baby aspirin, the crew shows up to the neighborhood with no tools, no blueprints, and no ability to build anything.
They're just standing around.
Yeah, you've actively neutralized your own regenerative treatment.
And the only way the body recovers that specific function is by waiting for the bone marrow to naturally produce a brand new batch of fresh megakaryocytes.
Which takes time.
Yeah, those will then shear off into fresh functional platelets to replace all the broken ones. That entire life cycle turnover takes about 7 to 10 days.
So purely from an efficacy standpoint, taking daily aspirin ruins the biological payload of the O shot.
Without a doubt.
But efficacy is only half of the equation here. The safety risks are arguably even more profound.
This is where things get really serious.
Because the O shot involves using needles in the clitoral area and the anterior vaginal wall. I mean, we're talking about highly vascular, incredibly sensitive areas.
Any injection inherently carries a risk of tissue trauma, right? But if a patient is on antithrombotic therapy, meaning their blood is chemically prevented from clotting efficiently, a tiny needle prick that should normally seal up in seconds.
It can escalate into a major problem.
It can escalate into a prolonged bleeding event.
Yeah.
We're talking about excessive bruising or worse, a hematoma, which is a really painful pooling of blood trapped beneath the tissue planes.
Ouch. So looking at the board, we have a medication that destroys the effectiveness of the treatment, and it drastically increases the risk of bleeding in a highly sensitive anatomical region.
Yes.
So the intuitive leap for most people is simple. Just stop taking the pill.
Right.
Take a break for a week, get the O shot, and then just resume the medication.
Well, this raises an important question. Why was the patient prescribed the aspirin in the first place?
Right. They aren't taking it for fun.
Exactly. And this is where the conversation absolutely must pivot from elective aesthetic wellness to critical cardiovascular safety.
It's a matter of life and death, really.
It is. The sources we have from our pain physicians and cardiologists are waving massive red flags here. Patients taking daily aspirin aren't usually taking it for joint pain or a headache.
No.
They're taking it for a history of stroke, atrial fibrillation, or ischemic heart disease.
Let's use a cardiovascular stent as the prime example here. If a patient had a stent placed in their coronary artery recently, their cardiologist almost certainly put them on daily low-dose aspirin, right?
Very standard.
Perhaps alongside another anti-platelet drug like clopidogrel. So if you place a bare metal stent in an artery, it is essentially like putting a wire mesh screen in the middle of a muddy river.
I think that's a great visual.
The blood is the river, the platelets are the debris, and naturally, debris is going to catch on that wire mesh, it's going to accumulate, and eventually it's going to dam the river.
Which is a heart attack.
Right, so the daily aspirin chemically coats that debris, permanently deactivating the platelets like we talked about, so they slip right through the mesh without sticking.
That is an excellent visualization of endothelialization and thrombosis, because the stent is a foreign body.
The body knows it shouldn't be there.
The immune system recognizes it immediately, and fully active platelets are biologically programmed to aggregate on foreign surfaces.
That's their job.
Right. The aspirin is the only thing preventing a massive clot. If a patient independently decides to just pause their aspirin because they read online that it ruins their PRP treatment, the biological rebound is incredibly severe.
Because the bone marrow is constantly churning out new platelets.
Exactly. Within days of stopping the aspirin, the bone marrow floods the circulatory system with millions of fresh, fully active, highly sticky platelets.
Oh, wow.
These new platelets circulate through the heart, they encounter the wire mesh of the stent, and they immediately do what they're designed to do.
They aggregate.
They aggregate. They form a massive clot. Stopping that medication prematurely without strict medical supervision can cause a vascular embolus, leading directly to a catastrophic heart attack or a stroke.
So you essentially invite a life-threatening cardiovascular event just to optimize a wellness procedure.
It's terrifying.
It highlights the sheer danger of siloed healthcare. So let's navigate the protocols provided in our sources. If a patient is on prescribed antiplatelet therapy, the aesthetic provider, the nurse practitioner, or the doctor administering the O shot, they cannot ethically or legally tell the patient to stop their heart medication.
They absolutely cannot. It's out of their scope.
Yeah.
The absolute consensus across all clinical guidelines requires explicit documented clearance from the prescribing cardiologist or the primary care physician.
They have to be in the loop.
The doctor managing the cardiovascular risk must evaluate the patient. If the stent is old enough, fully endothelialized, meaning the body's natural tissue has actually grown over the metal mesh, or if the overall cardiovascular risk is deemed low enough, then the cardiologist may grant permission to temporarily hold the aspirin.
So assuming the cardiologist writes that permission slip, what is the actual timeline to protect the efficacy of the O shot? As you mentioned earlier, because aspirin irreversibly destroys that COX-1 enzyme, we are waiting for a total platelet turnover.
Right. The standard protocol dictates that aspirin must be stopped 7 to 10 days prior to the blood draw.
Okay, 7 to 10 days.
That provides the bone marrow sufficient time to replace all the broken platelets with a fresh supply, which ensures that the plasma injected during the O-shot is dense with active growth factors.
But the protocol doesn't stop at the injection, right? I mean, you can't just take an aspirin in the car on the way home.
No, you really can't, because regenerative medicine relies on a sustained release.
Ah,
Once the concentrated platelets are injected into the vaginal tissue, they don't simply dump their entire payload of growth factors in 5 minutes and then disappear.
it's not a one-and-done thing.
No, they embed in the tissue matrix, and they continuously signal the local stem cells over the next several days to initiate that angiogenesis.
So if a patient takes an aspirin immediately after the procedure,
That systemic drug will reach the local injection site and permanently deactivate those freshly injected platelets before they can even finish their work.
you would basically be firing the construction crew on their first afternoon on the job.
Exactly.
So the protocol requires remaining off the aspirin for an additional 7 to 10 days after the procedure.
Yes, unfortunately.
That is a total window of 2 to 3 weeks without cardiovascular protection, which underscores exactly why a cardiologist has to be the one to approve it.
Precisely. It is not a decision to be taken lightly. Now, we should probably contrast this with other common medications, because the mechanism of action determines the protocol.
Yeah, what if a patient is taking ibuprofen or naproxen for a sore back?
Right. Let's dig into how the reversible NSAIDs differ mechanically from aspirin, because they do differ.
Okay.
Ibuprofen and naproxen are competitive reversible inhibitors. They do travel to the platelet, and they dock inside the COX enzyme, which prevents the platelet from aggregating.
Okay.
However, they do not destroy the enzyme.
Ah, so they just block the doorway.
Exactly. They simply occupy the space temporarily. Once the drug metabolizes and clears the bloodstream, it detaches from the enzyme, and the platelet regains full normal function.
The platelet survives the encounter. It isn't permanently disabled.
Right.
So the timeline for those medications must be much shorter.
Much shorter. Because they clear the system relatively quickly, protocols typically only require holding ibuprofen or naproxen for about 48 to 72 hours prior to the procedure, and then 48 to 72 hours after.
Wow, so much more manageable. Let's pivot to the heavy-duty blood thinners. The direct oral anticoagulants like Eliquis, Xarelto, or Pradaxa.
The big ones.
Yeah, these are the drugs given to prevent strokes in patients with atrial fibrillation. Do these medications also ruin the PRP growth factors?
Actually, no. They operate on an entirely different physiological axis.
Really?
Yeah. Aspirin target platelets. Drugs like Xarelto and Eliquis, they target the coagulation cascade. Specifically, proteins in the blood plasma, like factors A or thrombin.
So they sort of bypass the platelets entirely.
Exactly. They do not inhibit the platelet's ability to activate or release its growth factors at all. So from a purely efficacy standpoint, they do not ruin the regenerative payload of the PRP.
Oh, that's great news. But I imagine the bleeding risk remains.
A profound bleeding risk.
Right.
Because they are so effective at inhibiting the coagulation cascade, the physical safety during the injection is the absolute sole concern.
Right.
The protocols for these direct thrombin inhibitors focus entirely on ensuring the blood can clot normally at the injection sites. Depending on the drug's half-life and also the patient's kidney function, cardiologists might recommend holding it for just 48 hours or sometimes up to 7 days prior.
Depending on the person.
Right. And crucially, because these drugs don't damage the platelets, patients can often restart them the very next morning.
The very next day. So what does this all mean? Let's bring this all together for you listening. If you are someone taking daily cardiovascular medication, regenerative therapies like the O-shot are not automatically off the table.
No, not at all.
You don't have to passively accept decreased sexual function or urinary incontinence, but it requires a meticulously orchestrated medical bridge between the provider administering your wellness treatment and the cardiologist managing your heart.
And if we connect this to the bigger picture, it is a masterclass in why transparency in healthcare is non-negotiable.
It really is.
An aesthetic provider, they cannot protect you from a hematoma if they do not know you are on a blood thinner. And a cardiologist cannot advise you on the severe risks of stopping your aspirin if they do not know you are seeking out an elective PRP treatment.
You can't keep secrets from your doctors.
No. We have to stop treating our bodies like a collection of isolated parts. The exact same blood pumping through your newly placed cardiac stent is the blood being drawn, concentrated, and injected to rejuvenate your pelvic floor.
It is a closed, beautifully complex loop. Just because a therapy uses your own natural blood doesn't mean it exists in a vacuum. Your plasma is a real-time chemical record of every choice you make and every pill you take.
Knowledge is most valuable when it is understood and applied across your entire care team. True holistic health means acknowledging that every single intervention, no matter how small, ripples across the entire system.
Which leaves us with a really fascinating final thought for you to ponder. We just spent this deep dive exploring how one tiny, over-the-counter baby aspirin can completely rewrite the cellular tools your body has access to during an advanced medical procedure.
It literally disables your own biological construction crew.
It does. So it makes you wonder, what other hidden interactions are occurring in your body right now? What other mundane daily habits, morning supplements, or seemingly harmless routines are quietly rewriting your body's natural ability to repair and regenerate itself completely under the radar?
It's a big question.
It is. We spend so much time searching for the next massive breakthrough in wellness, we might just be ignoring the profound power of what is sitting right there in our daily pill organizer. Thanks for diving deep with us.